My name is Garrity, and this is my process speech. I am going to show you the steps to stopping severe hemorrhaging, which is bleeding. I have two helpers today. One of them is Miss Haley Louder. She's going to hold my board for me, and the other one is my husband, Ryan Garrity. He's going to be my casualty. Those of you that are familiar with civilian medical terminology and trauma treatment, in the civilian world, we triage patients by airway, which is our A, our B, which is breathing, and C, which is circulation, more commonly called the ABCs. Airway is determining whether or not the patient has a patent airway, which means does the patient have the ability to breathe? Is there an object obstructing the ability to breathe in either the mouth or the throat? B is breathing, which is self-explanatory. Can the patient breathe? Is the patient breathing? And circulation is whether or not the patient is bleeding. In the military, they have a group of people that determine what the protocol for teaching medical trauma response is going to be. And these people are down in Fort Sam Houston, San Antonio, Texas, and I was stationed at Fort Campbell, Kentucky, which is battle ready all the time. So we have the most up-to-the-date, top-of-the-line training. This group of people went through and looked at the statistics and discovered overwhelmingly that over 3/4 of the casualties on the battlefield were due to excessive hemorrhaging, which is bleeding out in the battlefield essentially. So they decided to change the protocol from the ABCs to CBAs. Our new triage process is called circulation, breathing, and airway. The reason they did this is, of course, if you have a casualty on the battlefield that is screaming and yelling that his leg is blown off or he's got a hole in his stomach, obviously he's breathing and he has patent airway. So the most important thing, the thing that needs to be treated first, is the circulation. I'm going to take you through the steps of treating excessive bleeding. So we have our patient here, our casualty, Mr. Ryan Garrity, who has a wound right here on the outside of his arm. The first step is going to be to grab your field dressing. Each of the pieces of equipment that we are going to use are carried on every soldier. They are either carried on the IBA, which is the battle armor, or they are carried in the pockets on either side of the ACUs. We're going to take our field dressing and we're going to open the field dressing up. Careful not to touch the white pad that's in the middle because we want to make sure that the dressing stays sanitary. We want to, although there will be dust and debris in the wound, try and keep the wound as clean as possible to prevent any kind of infection from happening. You always use the soldier who you are treating equipment on themselves. That way, if you need your equipment, if you get wounded, you have it available on your body. When you're putting the dressing on, you want to make sure to cover all of the white above and below to make sure that the dressing and the wound stay sanitary. You're going to tie the knot loosely on the top of the wound, and you want to make sure that there are 2 finger spaces between the wound and the knot. That's to assure that you're applying enough pressure to the wound to slow or stop the bleeding, but to make sure you're not cutting off the circulation of your patient. Now, in order to assure that you're not cutting off the circulation in your patient, you're going to check what is called PMS. PMS is pulse, motor, and sensory. You're going to check the radial pulse and make sure the patient still has a pulse. You're going to make sure the patient can sense that you are touching their hand, so ask them if they can feel this. And you're going to ask the patient to grab your fingers. Say, will you squeeze? Okay, so the patient's doing that. We're assuming that we're not cutting off circulation. Now, if the patient is still bleeding and you start to notice some blood coming through the wound or the dressing, you're going to ask the patient to elevate their arm, and you're going to do this from 2 to 4 minutes. This is not always practical on a battlefield. You don't always have that amount of time, but that's the textbook way to do this. After 2 to 4 minutes, if the patient is still bleeding, you're going to progress to the next step. The next step in this process is going to be making use of the cravat. You're going to take the cravat, wad it up in a ball, And without taking off the dressing, because you don't want to contaminate a sterile site, you're going to put the cravat on top of the dressing. You're going to open your second field dressing, which it's okay if it gets stuff on it because the site is already sanitary, so you're not worrying about keeping it nice and clean. And you're going to put this dressing directly on top of the previous dressing. You're going to tie this dressing a little bit tighter, but you're going to still try and make sure you're not cutting off the circulation in the patient's arm. So the idea behind this is when you put your knot on top of the dressing, you maintain one finger between the knot and the dressing. Again, you're going to check PMS, check the radial pulse, make sure he can feel you touching his hand, and ask him to squeeze your fingers. If the patient is still bleeding after this, we're going to progress to the final step, which is applying the CAT tourniquet. CAT stands for Combat Applied Tourniquet. You're going to open the tourniquet without taking off the dressing, and you're going to put the tourniquet above the dressing. You never place a tourniquet on a joint. You always want the tourniquet to be 2 to 4 inches above the wound. When you're applying this step, you can make it as tight as you want. You're not concerned with cutting off circulation at this point. In fact, that's the whole idea. So you're going to go ahead and tighten it as tight as you possibly can until the bright red bleeding stops. Once you've tightened it until the bright red bleeding stops, you're going to lock the CAT tourniquet and you're going to secure it with the strap on top. Old school style said blood or mud. You put a T on the patient's forehead and you write the time. That way you could tell when the tourniquet had been applied, and they would try and get the tourniquet off and get the patient to a surgeon within 6 hours. Iraq style, we used a permanent marker because although blood was readily available, mud wasn't always. So we would put a T on the top of their head and write the time that the tourniquet was applied. Timing wasn't as important because with new medical advancements, a patient could go 12 to 18 hours without having any damage to the wound. And that is the process of stopping excessive bleeding.